Nice to come and talk to you all, and I'll be introducing you to this device called the Mobile Destruction Unit, or MDU, the thing that can break down nitrous oxide. We've had a couple of these in our trust, Manchester University NHS Foundation Trust, for the last 6 months or so, and we've had the opportunity, supported by our sustainability colleagues, to take some measurements in the clinical workplace to see how they perform with real patients, which of course is potentially a big concern because labour is not known as a predictable and controlled experience. So there's reasons to think that this might be quite challenging to implement. So let's put my slides on and I'll talk you through a little bit of the context and then some of our work. So what you're going to see on the first slide is actually a colleague of mine posing with a demand valve, the thing that most women in labour will use to get nitrous oxide or gas and air. And if we just show the little arrows, when she takes a breath in comes a lungful of nitrous oxide and oxygen mixed, and when she takes a breath out with the next arrow, it's expired through that valve into the room. So every breath ends up going straight out into the atmosphere, but via the room that's got maybe the birth partner and the midwives and so on. Next slide, please. And as has already been mentioned, there's a potential issue here, which is not only environmental, but occupational. So I, as an anaesthetist, don't spend a great deal of time at the bedside for women in labour, but my midwifery colleagues do. And there's a potential, if this isn't dealt with, that they will exceed those levels, which Andrew's already mentioned. Next slide. And we've also heard that there are some alternatives, and actually this is my job as an anaesthetist, to come along and offer these things like remifentanil and epidurals to people who request them, and that's absolutely fine and they're very effective. But I think the point here is that we couldn't just make a switch away from nitrous, even if we wanted to, overnight, because, well, number one, the patients may not wish for it, I think, as has already been well outlined, but also I'm not sure we've got the staff or the space or the monitoring to offer those enhanced techniques. So next slide, please. So this is the aforementioned MDU, or Mobile Destruction Unit. I'll just talk you through what this box has got in it and how it works. So if we just go through the animations. So first of all, it's got a catalyst in it, like a catalytic converter in your car, and it breaks down, according to the manufacturer's data, about 99% of the nitrous oxide that goes into it. Next one, please. It takes about 20 minutes to warm up when you plug it in, but you can leave it plugged in, for example, if you've got a room that's commonly used. Next one, please. You can see here that this is shown with a face mask, which is what the manufacturer recommends, but we'll talk about that in just a minute in terms of alternative devices. Next one, please. And this is the technology that BPR have contributed, which is this special demand valve that's actually got a scavenging shroud. So as opposed to the one I showed at the start, this has got two tubes, one for the gas and air to come in through and one for what the patient exhales to go out through. Next arrow, please. And you can see that the exhaled gas is drawn in through that hose into the box where it's broken down. Next slide, please. So when we got one of these, we did a bench experiment just to see what would happen in ideal circumstances. Now, you can't quite make it out from the photograph, but what that shows is the MDU plugged into what we call a test lung. So it's basically a big set of rubber bellows that are used to test ventilators. And we use that to do simulated breaths of gas and air with and without the machine. And I don't know how well you can make it out in the results table next door, but you can see that at quite close range, we monitored the levels of nitrous oxide, and we found that with the MDU, it was virtually undetectable. Without the MDU, there were levels that were maybe not above that 100 parts per million, but they were detectable throughout the course of the experiment. So in ideal circumstances, it looks like it works well. But as I mentioned at the start, labour is not well known for being predictable, and we were very intrigued to see how it performed in the real world. Next slide, please. So this is one of our delivery rooms at the birth centre at Wythenshawe Hospital, and we'll just put some arrows on to show you some key features. So here's where our nitrous oxide and oxygen outlets are at either side of the room, and another arrow shows that there's a nice plinth here just next to the window. I should point out these windows don't open, where you can put a nitrous oxide detector. So this is how we did our study. And if we put on the next couple of little animations, we set our nitrous oxide detector to take a level every 2 minutes, and we monitored that during the last 30 minutes of labour for a series of patients. We picked the last 30 minutes because some people were in for a very long time, some for a very short time, but almost everybody's in for at least half an hour. So that allowed us to compare like with like. And we started off this project without the MDU, and then we introduced the MDU in a sort of stepwise fashion. Now, we've already had a bit from Andrew about climate guilt, and I think this is really important. So I just wanted to illustrate that, you know, when it comes to patient information in this particular context, it's got to be short and to the point and easy to understand, but also note that we talk about our carbon footprint here, not the carbon footprint of the patient or her baby, but we are appealing to our patients to help us out with dealing with the trust's problem. And I think that's probably the way that this should be pitched in this context. Next slide, please. So here's the important bit. This is a thing called a run chart, and it's a way that lets you look at data that's got variation in it. You can see on the bottom of the graph, the scale shows the cases. So this is our first 12 cases. And on the side of the graph, you can see parts per million of nitrous oxide. And this is the readings that we obtained every 2 minutes, the average every 2 minutes in the last 30 minutes of labour without any destruction equipment. And you can see here that some of these levels are quite high, up to nearly 200, and some of them are very low. And this indicates how variable people are in the way that they use these techniques. But we've drawn an orange line through the middle, and that's the median. So that's like an average of what we have without any destruction equipment, and it's around 45 parts per million. So not the sort of thing that would make your occupational health officer, you know, really upset, but something that's measurable and significant. So then we introduced the MDU, and I've put a little picture of a mouthpiece above both of these sections of the graph because that's what our midwives tend to use. So historically, that's what we're used to at Wythenshawe Hospital. And we decided we were just going to change one thing at a time, and we didn't expect this to work very well because we'd heard from Medclaire, the manufacturer of the MDU, that they felt, and this is very rational, that covering both the mouth and the nose might cause more exhaled nitrous oxide to be captured. But you can actually see that apart from the first of these 8 cases where we used the MDU and the mouthpiece, all of them were below that initial median. And when you do quality improvement science, this is what's called a shift. So we've got 7 points, all below the initial median, and this is very unlikely to happen by chance. So this is a result that we think has arisen from using the MDU with the mouthpiece. But we wanted to then test it as directed, and if we can introduce the next part of the animation, you can see here that we used what I would call a standard anaesthetic face mask. So this has got a sort of air-filled cuff that goes over the nose, under the chin, and you can see that the graph kind of looks like it looked in the original state, and we thought that's very unexpected. But when we talked to the midwives, they said that actually these masks can be quite claustrophobic when they're used for a prolonged period of time, and these peaks they thought were associated with patients who wore glasses or spectacles because the air-filled cuff kind of gets in the way of them and stops the patient from being able to see. I thought that was a really obvious point, but one that I didn't figure out prior to doing this work and talking to the midwives about what they observed. So then in the final stage, if you can show the last piece, we just used a skinnier face mask. So I call this a low profile face mask that kind of fits under the glasses. And you can see that our graph looks very good here. And actually the number here is only 8.7 parts per million median overall. So this is a really substantial reduction that we saw of nearly of around 80%. So on to the next slide, please. So what did we learn from this? Well, I think there's a few things to take here. First of all, using the MDU can result in a substantial reduction in the ambient levels of nitrous oxide. I think that's really important from an occupational point of view, and it's probably also really important from a climate point of view, but just bear in mind that we were measuring levels in the room and we can't quantify exactly how much of the nitrous oxide was broken down. The other thing to say is that it's possible for it not to work if you don't implement it in a way that works for the patients and works for the midwives. And it was really interesting that the thing that our midwives have been used to using was actually highly effective. And when I talked to them about what that was all about, they said, well, we've been training patients for years to keep the mouthpiece in between their teeth and breathe out through it, even though that doesn't really have a function when you don't have the MDU. But they said that helps people to focus and to control their breathing. And it seems to be that effect that accounts for that effectiveness. And then the low profile mask pretty much does what the manufacturers expected. It's just a little amendment to what we were initially delivered to work in the particular context. So I think, you know, technology works, but how it's implemented is really, really important. I'm just going to move on to my final slide now, which should be a QR code. And we wrote this up actually, Andrew, the previous speaker, was one of our co-authors. We've got some feedback from the midwives in there as well. And if you want to point your phones at that, it'll take you to a copy of the study, which explains in much greater detail than I can fit it in 10 minutes, exactly what we did and exactly what we found. So thank you very much for your attention, and I'm looking forward to some questions later on, but I'll hand back to you, Vivian, just now.